SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode 37. My name is Scott Okuno, medical oncologist at Mayo Clinic and chief medical officer at SARC. At SARC Talk, we interview interesting people who are connected to sarcoma, where we can all share and spread the knowledge about sarcoma. Our guest today is Professor Robin Jones. He's a consultant medical oncologist and head of the sarcoma unit at the Royal Marsden Hospital in London, England. Professor Jones trained in medical oncology at the Royal Marsden, and then after his training, he did leave for 4 years, 2010 through 2014, to head up the sarcoma program at the University of Washington at the Fred Hutch Cancer Center. In 2014, he returned back to the Royal Marsden, where he is a professor and lead of the sarcoma unit. Welcome, Dr. Jones.
Thank you so much for the invitation. It's great to be with you today.
Yeah. Well, thank you for spending some time with us here. And I know that you and I have known each other for several years, for years actually. And, we follow each other's career paths along the way. And maybe you can share with our audience a little bit about your present role at the Royal Marsden and how your training and the career path evolved. And we can follow up from there.
Yeah, thank you so much. So yes, as you mentioned, I trained in the United Kingdom. I did my oncology training at the Royal Marsden and the Institute of Cancer Research, and during that time had many great mentors, including Ian Judson, David Cunningham, Martin Gore, Ian Smith, Mitch Dowsett, Johan de Bono, who all have helped me so much over the years. As a training doctor, did a lot of work in breast cancer, but became increasingly interested in sarcomas after doing a post with Ian Judson for 6 months, and it struck me that these tumors were all very obviously very rare, but there was so much heterogeneity within this classification of sarcoma that I instantly became interested and began seeking ways to pursue a career in sarcomas. As you mentioned, I then moved to the University of Washington and the Fred Hutchinson Cancer Research Center in 2010, which was fantastic and such a wonderful organization, such a wonderful place to live, and had 4.5 nearly 5 years, very happy years in Seattle, but due to a variety of reasons, in the end had to move back to the UK and move back to the Royal Marsden and the ICR where I am now. And essentially, I see sarcoma patients with my colleagues at the Royal Marsden. I lead the sarcoma unit and the clinical trials team in sarcomas here, but also work closely with colleagues at the ICR, including Paul Wang and Janet Shipley. So that's my story in a nutshell.
You said that you had a great experience with Ian Judson, and that kind of changed your trajectory. Tell us a little bit more about that, because a lot of the people that we have on our SARC Talk have been influenced heavily by these happenstance interactions and all of a sudden change the whole career to go from something else to sarcoma. So tell us a little bit more.
So yeah, that was a great opportunity for me. It was just after all the excitement regarding the introduction of imatinib in GISTs, and very often in clinic, we would have just great discussions regarding the biology of sarcomas, as I mentioned, the heterogeneity of sarcomas. And it became clear to me that there was so much work that we needed to do in terms of improving treatment options for patients with sarcomas that I was instantly hooked, and I could see the potential for research in terms of clinical trials, but also in terms of laboratory research. We clearly need a better understanding of the underlying mechanisms of many sarcomas, and I was just, as I say, hooked immediately. And working with such a great oncologist as Ian, as I say, was just such a fantastic opportunity for me.
You did train at the Royal Marsden and then had your first career job outside.
Yes.
And then you learned a lot of skills. How was it? And tell us a little bit more about how was it to come back to an institution that when you were there, you were a trainee, and now you're coming back as a full-fledged 5-year sarcoma expert. So how did that happen? Tell us a little bit more.
That's a great question, and a question that I've never been asked before. I think in certain ways the move back was relatively easy. In other ways, I suppose there were certain challenges. I think the UK healthcare system is under pressure right now. There's a considerable workload for all oncologists and indeed all clinicians within the UK. But I'd obviously learnt a lot working in Seattle and working with my fantastic colleagues at the University of Washington. So I had many excellent collaborators at the University of Washington and the Fred Hutch, and indeed across the US. And I think that that's one of the major things that I really learnt from working in the US and being involved with organizations such as SARC and CTOS is the importance of collaboration, and bringing that back to the Royal Marsden and the ICR has been incredibly helpful, and I think the organizations really appreciate that. So I think it's been just wonderful working both in the United States and in the UK, and I've been very fortunate to be able to do that.
ICR is a little bit of a unique opportunity that you have in the UK. And I know you said you work with Paul and his teammates over there. Can you tell us a little bit more of how the clinical part, as you said, works with the ICR?
Yes, so for those that are unfamiliar, the Royal Marsden Hospital is in a way, the organization that sees patients and runs clinical trials. And the ICR is very much the sister organization that does all of the basic and translational research. So very much the laboratory side of the two organizations. And Paul Wang and I have built up a fantastic working relationship, and we've been able to join together, the two aspects of sarcoma research, so the clinical trials and also the laboratory work that Paul does at the ICR. And indeed, we're hoping to enable other groups, other tumor types within the ICR to work more closely together.
That's an important aspect, Dr. Jones, because many of our centers are cancer centers. And it's kind of like that same model is you have the clinical part, you got the clinical research part, but you also got a basic science part. And many of our major sites has scientists that are very interested in cancer, but you're very fortunate to have someone who is interested as a scientist, but is also interested in sarcoma.
Indeed.
That's really a special thing and a great opportunity, and we look forward to more how this evolves over time, because I think that's the model. There's enough there that, as you said, other groups wanna redo this a little bit more even at your institution.
I agree, Dr. Okuno, and I think there's so much potential at our institution, but also a number of institutions throughout Europe and North America and Asia. So I think that's one of the major points that I'd like to make: the importance of collaboration in rare cancers, and that we all really need to work together. And again, I think SARC is very, very important in that respect.
Yeah. To follow up on that, SARC, our fathers and mothers who started all of the SARC had the vision to have a big component, what we call Discovery Translational Committee, which are really the basic science people to drive the science. But we also need the clinical expertise, the clinical trialist approach. What are the right trials to do in conjunction? So I think, we're learning from what you're doing, and, we're just continuing to evolve. Dr. Jones, you also said that you had the ability to collaborate clinically. And some of our colleagues that might be listening might be a solo sarcoma practice, a solo sarcoma expert, as they would say. What advice would you have for those individuals? Because you and I work at institutions where in the clinic today, we had so many sarcoma physicians in there, providers, that, it got too loud. We had to kind of like, I had to leave and go. So, so just to that point, because we have collaboration in the clinic, and I don't have to phone a friend, email a friend. They're just there next to me, sitting next to me, seeing their patients, and we discuss that. So how would you say that that works with you, where you practice now? And then how would you say, if you are solo, how to gain that interaction?
Yeah, again, that's a fantastic question, and I think taking a step back, sarcomas are so challenging in many ways to treat, that it is important to have people to discuss treatment, discuss cases, bounce ideas off. And it's similar to you. I work with a fantastic group of radiation oncologists, medical oncologists, surgeons, pathologists, and we've just had our multidisciplinary team meeting. And I think being able to talk to people and to, as I say, almost just bounce ideas off people is really, really important. And I think for oncologists or surgeons that in a way, as you say, are working solo, meeting other oncologists, building up that rapport with other oncologists internationally and nationally is really, really important, so that you can get in touch if you do have a very challenging situation and you just want to sort of run something past other people. And email is good for just asking very direct and succinct questions, but sometimes it's just nice to phone somebody, or to almost have a video call with somebody, just to go through things. As I say, it's so nice to talk to you today, because we never really get the chance to talk. We always just say hello to each other, so I'm really happy to. But I think again it comes back to collaboration, and the role of organizations such as SARC, CTOS, ASCO, ESMO, in terms of bringing us all together. And when you know somebody, when you've met them face to face, it's so much easier then to talk and to chat through things. So I think that's so important in sarcomas, because we are faced with sometimes very unique challenges.
You brought up a couple times the heterogeneity of the sarcomas and the nuances and experiences. And you and I are involved in the email chain to help patient care of an
Yes.
unusual case that one of our colleagues in the United States is sending around to get input too. So to that point, I do think once you know the people, you are very more comfortable at reaching out. Hey, I know somebody at Royal. I know Robin. I know Scott. I know Nita down to MD, all these different individuals, or Seth, um, you know, people that are in the community that, with collective experience might have some better insight or some insight in the next step. So to your point, that's right. And I think if you're practicing alone, we have multiple opportunities for that discussion. And we were just thinking we have a lot of new junior staff. And when I say junior, out of fellowship, 5 years into practice, we went through COVID. So those meetings, those connections were hard, as
Yeah,
you said.
great point. Mm.
We do have SARC, has a multidisciplinary tumor board monthly. We do know that you can bring cases, any cases, and present. So I'm just making a plug for our tumor board, but each one, I think CTOS is now having a tumor board. There are other groups now that are launching into these type of activities. So I do agree. It's all for the patients. And as you said, we're a very collaborative group of people, and no one owns the market because it's so varied, as we would say.
Yeah, again, very good points, Dr. Okuno. Fantastic points.
When we were thinking about, talking to you earlier, we said, well, how does the UK in your role have all access to all these major phase 3 trials? And I'm just going to name some of them. I had to write them down here. The announced trial, SARC 21, which was one of our larger studies
Yes,
using
indeed.
doxorubicin and everphosphamide, the eribulin carbazine discussion, the trabectedin carbazine, Picasso. Remember Picasso?
I do.
Solutor, the Selexinor, and those are just the soft tissue tumors. And your group has been involved in the GIST trials, such as Intrigue, Insight, the avapritinib, regorafenib study, the Navigator, the Invictus. These are major practice-changing phase 3 studies, and when I was preparing, you're on all of them. So, Robin, share how that happens, and how do we learn from how you and your team position themselves, to put people on and be, um, intimately involved in the design, conduct, and reporting out of these studies?
Yeah, again, another fantastic question. I think both in the Fred Hutch and UW, but also at the Royal Marsden, I've been very fortunate to have just fantastic people working with me, both in terms of my fellow oncologists, but also in terms of the clinical trials staff. So I think for any young oncologist, medical oncologist setting up a sarcoma clinical trials group, I'd say that the really important thing is to have fantastic staff that get things done, and you almost don't have to think about it. You do, but I think having staff that really care and are very, very diligent is so important. And in terms of your first point regarding involvement in clinical trials, I suppose that ties in with our previous discussion regarding meeting people, going to meetings, being involved in organisations such as SARC, also the EORTC in Europe, being involved in organisations such as CTOS, ASCO, ESMO. I think all of these things are really, really important, and meeting people, having discussions with people regarding exciting new treatments in the pipeline, and being involved in the development of drugs from the phase 1 stage onwards. So I think it's a mixture of many things, but I think essentially you really do need a great group of people, a great team working with you, and also meeting other investigators, meeting within collaborative groups such as SARC and the EORTC, and also interaction with colleagues in pharma as well.
Yeah. I know that, You bring up the word collaboration, which is key. Um, you're very busy clinically. You're very busy administratively. You're involved in education, research, the clinical trial part. How do you balance all of that? And because some of us are, you know, try to do all of it and some fail miserably, something has to give. But, the reality you've said is that you have great people that you work with, but you give direction and support. But, you know, as somebody who is starting in their career, what advice would you give them to say is, hey, this is Robin Jones 10, 20 years down the road, but hey, if you there, you don't look where he is now because that is just a path that is a long thing. But kind of how do you balance? And then more importantly is what advice would you give to junior staff that are going to the meetings, doing the collaboration, making the contacts, being involved in the early development?
Yeah, I'd say, just introduce yourself to people. I think that the poster sessions at ASCO, ESMO, CETOS, there's such a great opportunity to talk to other researchers from around the world regarding their work, regarding exciting developments. So I think that sort of interaction is really, really important, that you introduce yourself and get to know people. I think one of the other things that's really important is that your institution is supportive. I think it's crucial to have mentors within your organization that can help you navigate. If there are glitches or if there are delays with things, somebody that you can again talk to about how to circumvent problems. And certainly when I worked at UW and the Fred Hutch, I had so many fantastic mentors that I'm really, really grateful to for all their guidance and help in terms of adjusting to the American system. Even though, as I told you before, I'm American. Really, I just need to work on the accent.
There you go.
But
Yeah.
but I think, as I say, it's a mixture of things, and being very open and again, to use the word collaborative, I think is really essential.
You and I have been blessed by having people that mentored us and allowed us to continue our careers and professionally grow. You are a mentor to a lot of junior staff now too, and as you start to, I'm not saying that you're retiring or anything like that, but as you're starting to impart wisdom based on experiences, good and bad, kind of what wisdoms would you be giving a junior staff if they want to develop a career in sarcoma? Because you have house officers that might be interested, you might, interact, but what would you say to someone that they want to build a career in sarcoma?
I think again, this comes back to having mentors and people that can guide and help you. And I would say that CETOS, SARC, the ERTC are all absolutely essential in that respect, because in a way sarcomas are so different to well, certainly so different to other more common cancer types, that you really need that support from I'd say people all over the world in many ways. And I think for people that are just starting out, having that sort of solid base in terms of mentors at your institution is critical, but also building up a wider group of people that you can call upon if you've got any queries or questions, or you just need, as I say, just need somebody to bounce ideas off. So I think that would be my my advice to people to have people that can guide you and give you ideas, and almost sometimes just challenge you and challenge your thoughts on things, rather than just agree with you, if that makes
That's
sense.
100%. And, if we weren't challenged, we'll still be driving horse and buggies around here. So just
Well, indeed.
For those that are listening, there are a lot of opportunities through our cooperative group mechanisms in the US, the Alliance, NRG, SWOG, ECOG, which are very similar to what Dr. Jones is saying too in Europe, which is the EORTC, and those type of cooperative groups across the pond, as we say. We have seen a lot of different changes occur in research in sarcoma in the last 20 years, 25, 30 years. Where do you see research, the clinical trial spectrum evolving in the next 5 years for sarcoma?
Again, I think that's a great question. I hope that there'll be more emphasis on biological rationale and marker selection for clinical trial participation, and that we'll see more emphasis on treating specific sarcoma subtypes rather than all-comer sarcoma trials. I think with such a variety of different diseases, it's difficult to be specific or precise about how things will evolve over the next 5 years, but I certainly think that there'll be more emphasis on the underlying biology.
You bring up a point there, Robin, that the days of let's treat all advanced metastatic sarcoma studies is done. And, we have to have more biological driven. That's why the collaboration that you have with ICR and the basic science team is important. We need to have appropriate endpoints to our studies because we've discussed many times that, comparator arms and whatnot. So that's
Indeed.
where the
Yeah.
clinical trialist has to fit into the picture. You can have biology, but if you design the trial wrong, you're going to be in a big deal. But there are limited resources. Sarcoma is, 70 different diseases. And as you and I would say, if you see one sarcoma, yep, you've seen one sarcoma. You haven't seen all of them, okay? So to that point, how do you see us in the sarcoma world trying to get the attention of industry, to get the attention of scientists that might be doing great things but not doing sarcoma, and how do you see us funding this, because you said there are challenges at your across all health systems, let's be honest, not just in the UK, it's us. How do you see us navigating that?
Yeah, I think again, there's not a single answer to that. I think the starting point is that there have been a number of positive randomized trials in sarcomas over the last 6 months, which is something that we should really advertise and highlight to people outside the sarcoma community. Trials that are clearly, unequivocally positive, and I think that is definitely a really good thing. In terms of obtaining funding, it will always be a challenge for rare cancers, and we'll have to just continue to obtain funding from lots of different sources, in my opinion. National funding, charity funding, philanthropy, you name it. I think we'll always have to. I think Alex Kroenke's phrase, almost a mosaic of different funding sources. So it will always be challenging in rare cancers, but I think we have to just, again, work together and find funding from various different sources when we can. But I don't think there's a single magic answer to that question, unfortunately. And I think there'll continue to be sort of ups and downs in terms of research in sarcomas, but we just need to, as I say, circumvent and work around these problems. And for younger investigators, I think having institutional support and institutional mentors in that respect is really, really important. As I say, when I first started at the University of Washington and Fred Hutch, I was very fortunate to have people like Matt Cheever, Chappie Conrad, Fred Applebaum, Mark Stewart, and loads of other people that were just amazing in terms of giving me advice and giving me very, very sort of practical advice on how to navigate in institutional systems and policies.
You bring up a point. You do need somebody to shepherd you through each institutional's bureaucracy or labyrinth, and it is correct. For those that are thinking or listening that, is the sarcoma structures that we have across the world complicated? No. Has funding been a problem 30 years ago? Yes. Are funding problem today? Yes. So those will never go away. But what we have to kind of continue to think through is that if we're going to invest time and money in trials and research, we need to go down paths that use our time limited, funds that are limited to the best use. And this is where collaboration and appropriately designing trials to succeed or not succeed, because not all trials are going to succeed, even with the best science. And as long as we go in with a good faith effort, I think we'll get there. And I'm looking for the next 5 years, 10 years, doing clinical trial work as well. Those that are listening might not know too much how patients get funneled to different centers of excellence in the UK. Robin, since you've been there and you know the system, maybe you can share with the group, how do the oncology patients with sarcoma get funneled to the certain centers in the UK?
Yeah, so in the UK, there's a centralized system. So all sarcoma patients need to be referred to a sarcoma center for confirmation of diagnosis and treatment. And I'd say that system works really well in the UK. There are a number of designated sarcoma centers throughout the country, and I, in a way, I wish that all countries had this centralized system where all patients are treated in designated centers. The French Sarcoma Group have, published conclusive evidence that that has an impact on outcome, that those patients treated at specialist centres do better than patients not treated at specialist centres. So I think it's a really good system, and I wish every country could adopt this approach.
Yeah, I think when you're referencing high volume cancer centers that see a lot of sarcoma have better outcomes compared to those that have less. And that's part of the reason why SARC tries to allow individuals to look at sites that have 70 plus sarcoma cases a year. Now, is 70 the right number? Is 50, the more the better, but the efficiency is there. So to your point, if you're listening and you try to get to centers or of people that have at least a good amount of new cases of sarcomas, because when you have 70 to 80 different soft tissue sarcoma histologies, you need a lot of experiences to do this. And I really like what you said, Robin, that the UK really has it set up. How can we in a more privatized area kind of work on it? That's the opportunity. We'll continue to work together on that.
Yeah, I agree, Scott. I think one of the things, clearly there's a huge difference between the UK and the United States, but I think the geography in the United States is just so different to the geography in the UK. The distances that people need to travel to get to a sarcoma center in the US sometimes are just mind blowing to somebody coming from such a small country as the UK. In my first clinic in the US at the Fred Hutch, I remember seeing a patient who came from Alaska. I think they lived closer to Russia than they did to Seattle, and I could see Chappie, Conrad, Eve Rodler, all my colleagues just could see that I was just blown away by this concept that patients were traveling such distances from Hawaii, from Montana, from Alaska. So I think that the geography is a real challenge in the US, but again, I think in many ways it comes back to collaboration. I worked really well with many of the community oncologists in all of the sort of states that referred patients to us, and have fond memories of visiting colleagues in in Oregon, in Montana, in Alaska, etc. So there is a way to sort of work through that and build a network, I suppose. But the geography, I think, is very different. It's not just the the nationalized healthcare system versus the privatized system, if that makes sense.
Yeah, you bring up an excellent point there, Dr. Jones, because um, I mean, I live in Rochester, Minnesota. Now, if you we're geographically isolated, and we do appreciate all the patients and the families that find the resources to come to Mayo Clinic. But to your point, a lot of them can't continue all their treatment here. And we've developed a huge system where we collaborate, as you said, and just similar to UW as well, collaboration. So, and you do that in the UK because they have to be sent to that place, but then ultimately you have to have a relationship too.
Absolutely correct. Absolutely correct. Yeah.
You and I have been working over the years trying to develop SARC trials, both in the US and to centers. And I know we're working on a trial right now at your place as well. But, how do you see like a SARC working with your structures, and how do you see that evolving over time?
So the first thing to say on this is that I'm absolutely delighted that I'm working with SARC again. Dr. Andrea Napolitano has been working with SARC, Dr. D'Angelo, to get the tebentafusp trial in clear cell sarcoma set up. And I'm just over the moon that we've been able to get the trial set up here, and I really hope that this is the start of a new sort of collaboration, really, with SARC in Europe. I think this is absolutely fantastic, and I know that I've spoken with you on a number of occasions and other people within SARC about doing this, but the fact that we finally got it to work, it just makes me so happy.
Yeah. I know we had a podcast with both Andrea and Sandra to talk about the clear cell sarcoma study and how it got developed and how the relationship developed over time. But it goes to what you said at the very beginning. Know who your colleagues are at your institution and your collaborators, and then this is what falls out of it, a trial that will hopefully help, get people with clear cell sarcoma on a clinical trial both in the UK and selected sites across the United States. And as you said, it's an additional proof of concept that it can be done. And then part of what SARC in each of our collaborating institutions across the world, we have to say where it makes sense. So we're excited about this. And those that are listening, and if you have clear cell, that live anywhere near the UK, you should get to Andrea and his team, or Robin over there at the Royal Marsden. And if you're in the US, we have sites at least up and running now at Memorial, and we have a couple other selected sites across the United States. So we agree.
This is just wonderful, and as I say, I'm just so happy that we've been able to do this, particularly for such a rare disease as clear cell sarcoma, which even for a sarcoma subtype is just incredibly rare. So this is wonderful.
Yeah, and this is where collaboration is. It doesn't make sense that every single cancer center activates it. We'll refer to those sites. So that's the key part.
Agreed.
So Dr. Jones, thank you. Thank you again for sharing your time, your expertise with us. Thank you for sharing your expertise with us, not only today, but over the years, and mentoring and collaborative work along the way. Any additional thoughts that you might have for me or for our audience?
I think again, it's just been so good to catch up with you, and I, as I say, maybe we should dedicate time
Exactly.
to. I think this has been really, really good to go over. A number of key sort of learning points for younger investigators. I think. For me, over the last year or so, the major highlight has been the positive trial in advanced chondrosarcoma of the death receptor 5 agonist. Again, chondrosarcoma is such a challenging disease, but to actually have a positive trial, randomized trial in that disease, I think is a really fantastic step forward. By definition, the patient population entered into that trial had very aggressive disease. So again, I think it's just great that the sarcoma community could come together and do such a trial. And I'm really happy that this trial is positive.
Yeah. So, Robin, I would be remiss if we didn't spend a little time talking about that trial, because you presented the data at CTOS about the DR5, that inhibitor there. And I think if people understand about that, I think that would be helpful, because we've tried a lot of different things in chondrosarcoma, and maybe you can share a little bit of kind of what that study was about, and kind of where you think that study is going to lead us in this, aggressive, previously really no other therapy area.
Yeah, so I think as you say, that this is such a challenging disease. So there are no approved, no effective therapies for chondrosarcoma. There are some preclinical data suggesting that this approach is beneficial in conventional chondrosarcoma, and over the last 10 years or so, a number of clinical observations from phase 1 trials that again, this approach resulted in benefit for patients with advanced chondrosarcoma. And of course, the phase 1 trial of ozekibart, or Inhibrx 109, there are a number of patients with conventional chondrosarcoma that benefited from treatment, that then resulted in proceeding to a randomized placebo-controlled trial. So the trial recruited patients with advanced chondrosarcoma with disease progression, resist disease progression within 6 months of entry, and the primary endpoints of the trial was progression-free survival by blinded independent central radiology review. And the trial met the primary endpoints, and I think the bottom line is that hopefully the drug will be approved by regulatory agencies and will be a treatment option for patients. there's also an ongoing trial of this agent in combination with irinotecan and temozolomide in Ewing sarcoma. So hopefully, this will lead to another treatment option, either single agent or in combination for a number of different sarcoma subtypes. And again, in terms of advanced chondrosarcoma, there's an ongoing trial of an IDH1 inhibitor in advanced chondrosarcoma currently recruiting. So this approach, again, there's a good rationale for using IDH1 inhibitors in IDH1 mutated chondrosarcoma, and hopefully this will also lead to another positive trial and another approval for this challenging disease. I have to mention that my friend, my dear friend Brian Van Tyne, who passed away at the end of last year, he and I worked on another IDH1 inhibitor in phase 1, phase 2 trial, a drug called oltacetinib, which also showed some activity in advanced chondrosarcoma. But I think, Scott, this comes back to your point that we need, in many ways, a better understanding of the biology of not only chondrosarcoma but other diseases, in terms of why some patients benefit from certain drugs and others don't.
Absolutely. And as you said, from the first study that you presented at CTOS, this was the first positive study in chondrosarcoma. As you shared, that there was, very well tolerated, and it did meet the primary endpoint.
Yes,
And
indeed.
it's a novel mechanism, but you said it took 10 years to get there. So these take a lot of time to get to, and once you get a positive study, is exciting. And as you said, they're going to build upon that, because the mechanism of action does lend itself to Ewing's, and you talked about that as well. And then there's a whole other pathway, which is the IDH1 mutated pathway. So, where that leads us, we'll find out. But the only one that we know of today is stuff that you presented at CTOS on behalf of the study team. And it was a double-blind placebo-controlled study, and you had to have progression going into it. So these are real progressing disease, and it did meet the primary endpoint. So yeah, I that's what started this whole podcast discussion. And I thought to myself, I'd like to learn more about it. But then I started thinking, like, there's a lot more of Dr. Jones than just that one study. But you're 100% on board. This is the first study in chondrosarcoma, and hopefully it's going to be looked at, and hopefully it becomes available clinically, and as we would say, FDA approved or EMA approved, or whatever government agency. So
yeah, I agree. And again, you make such a great point regarding the time that it takes to open clinical trials. I mean, the tebentafusp trial in clear cell sarcoma, Sandra and Andrea have been working on that, for 5 years at least. I mean, it's incredible. And again, that's why I'm so happy that that's finally come to fruition. It's just excellent news.
So you're pretty good at naming these names. So what was the name of the study, that the name of the Kizabart?
Oh, for the death receptor 5 agonist, ozekibart. Yeah. Ozekibart, yeah.
It has like an old, I remember, a Zekibart, yeah. So, but these are really unique, because the clear cell one, you just say it right off the top of your tongue there too. And I fortunately, or not, I stumble on these words. So
I had to practice a little bit right before doing that.
No,
so just repetition. Yeah.
Yeah, you had to make sure you look good up there. So it was good. So, and this is a field, and this is why it's exciting, that once we get a hold of a drug concept and it starts to work, it opens up a lot of opportunities.
Indeed.
And a lot of interest, and it spurs more interest in understanding the biology. And that's why you and Brian Van Tyne started going down the IDH1, and people are still interested in that. The DR5 agonist route is there, but it took years to get to that point. And maybe there's more to the DR5 and other tumors as well. And this is how but it takes time and momentum building. So we're all excited about hopefully that this will become available for us, and all of us that we're not on the trial have access to and you can share with our patients. So this is great.
Agreed. It's good news for our patients and good news for the community. Yeah.
Well, Robin, I know it's late in your evening there. We do appreciate you spending time with us, and we look forward to, this is probably the longest conversation you ever had.
we've had longest conversation we've had in years, I think, Scott. So
exactly. I add it all up. So this is it's great to spend a little bit of time with you and more importantly, to share kind of your thoughts and perspectives in the sarcoma field. And we appreciate it. So thank you again.
And just one thought again for younger investigators. I suppose we were just discussing the sort of timelines and that sometimes it can take years for projects to come to fruition. So I'd say that in many ways, resilience is really important in that respect. And I know that's easier said than done, but I'd say just keep plugging away at things and, as you rightly said, Scott, sometimes things don't work out, but you just got to keep plugging away, and eventually things will work out.
Exactly, and to that point, we're not on a short chat or stuff like that. Our careers are long, so enjoy it. Spend the time, meet the collaborators that you will work with, and develop friendships over time. So we appreciate it. Thanks, Robin.
Oh, pleasure. Thank you for the invitation.
For those that are listening, thank you again for spending some time with us in SARC Talk, and we look forward to a future time together. And if you have any questions or comments, please drop them in the comment section and we'll get back to you. So again, thank you all.
Thank you for listening to SARC Talk. Be sure to subscribe so you never miss an episode. To learn more about SARC, visit us at sarctrials.org. If you have questions or would like to suggest a topic, email us at sarctalk@sarctrials.org. SARC Talk is made possible through the generous support of Syrie Pharmaceuticals. Together, we can find a cure for all forms of sarcoma.